रहा है मैं क्या करूँ शुरू करूँ मूवी वगैरह है बोला है वो आपको आप उस पहले का respected dignitaries and delegates, welcome to MIT Pune's Maima Medical College and Dr. BSTR Hospital, Talegaon, Dabade. On behalf of the Department of Pathology, I, Dr. Janice Jason, extend my greetings to each one of you for joining us today as we celebrate the International Pathology Day 2025. We will start the program with a documentary on the glorious history of MIT Trust, our parent institution, and the inspiring journey of our founder, Executive Director and Managing Trustee, Mair MIT Group of Institutions, respected Dr. Vishwanath Karad sir.
सच कहूं, तब मैंने सोचा भी नहीं था कि ये एक छोटा सा बीज एक विशाल वटवृक्ष में फलीभूत होगा। सन 1981 में प्राध्यापक डॉक्टर विश्वनाथ कराड़ जी ने इस अनोखी दिशा में पहला कदम रखा था। शिक्षा व्यवस्था में निजीकरण के द्वारा ये ज्ञान गंगा जन जन तक ले जाने का एक सफल प्रयास मेरे माध्यम से हुआ था। प्राध्यापक डॉक्टर विश्वनाथ कराड़ जी, मैं आपका शुक्रगुजार हूं कि इस विचार का एक अग्रणी बनने का सौभाग्य आपने मुझे दिया। कारवां चल पड़ा, दिन प्रतिदिन मैं वृद्धिंगत होता गया। ना जाने शिक्षा क्षेत्र में कितने अभिनव प्रयोग मेरे माध्यम से किए गए। अभियांत्रिकी के साथ मेडिसिन, फार्मेसी, मैनेजमेंट, नौका अभियांत्रिकी, डिजाइन, संगीत, फिल्म और टीवी, आर्किटेक्चर, ऐसी अनेक शाखाओं की स्थापना संस्था के अंतर्गत हुई। मूल्याधिष्ठित वैश्विक शिक्षा पद्धति के माध्यम से विद्यार्थियों का सर्वांगीण विकास करने का विश्व का शायद ये पहला प्रयास था। साथ ही मेरे संस्थापक दूरदर्शी शिक्षाविद प्राध्यापक डॉक्टर विश्वनाथ दा कराड़ जी की विश्व शांति के प्रति उत्कट आस्था के कारण कई अद्वितीय उपक्रम साकार हुए। अंतरराष्ट्रीय स्तर पर इन शांति के प्रयासों को नवाजा गया। अनेक अद्भुत वास्तुओं का निर्माण हुआ। तत्वज्ञ संत श्री ज्ञानेश्वर माउली के आनंद स्थित सुंदर घाट, स्वर्ण जड़ित गरुड़ स्तंभ, विश्वरूप दर्शन मंच, तत्वज्ञ संत श्री तुकाराम महाराज के देहु स्थित ज्ञान कर्म भक्ति महाद्वार, मराठवाड़ा के रामेश्वर रोई स्थित श्री राम मंदिर, श्री राम रहीम मानवता सेतु, तथागत भगवान गौतम बुद्ध विहार, जामा मस्जिद और ख्वाजा जैनुद्दीन दरगाह, नेपाल के भूचाल पीड़ित लोगों के लिए बनाए गए 120 पक्के घर, भारत के प्रथम ग्राम माणा में निर्माण किया गया ऐतिहासिक श्री सरस्वती मंदिर और स्वर्ग की ओर मार्ग क्रमण कर रहे पांडवों की भव्य कांस्य की प्रतिमाएं, विश्वधर्मी डॉक्टर विश्वनाथ कराड़ जी की संकल्पना से निर्मित ये सारे ईश्वरीय वास्तुशिल्प मेरे चरित्र को और भी गौरवान्वित करते हैं। 2018 में बना तत्वज्ञ संत श्री ज्ञानेश्वर विश्व शांति सभागृह, ये विश्व का सबसे बड़ा विश्व शांति गुंबद तो वास्तव में मेरा मुकुटमणि है। विश्व को ऐसी वास्तु प्रदान कर पाना ये मेरा एक और सौभाग्य था। शायद पहली बार अध्यात्म शास्त्र की वैज्ञानिक प्रयोगशाला इस संकल्पना का उच्चारण इस वास्तु के माध्यम से हुआ। तत्वज्ञ संत श्री ज्ञानेश्वर से तत्वज्ञ वैज्ञानिक डॉक्टर अल्बर्ट आइंस्टाइन, ये अध्यात्म से विज्ञान तक के अनोखे सफर का एक आयाम दुनिया में शायद पहली बार निश्चित किया गया। 5 विश्वविद्यालय विश्व शांति का संदेश, विश्व कल्याण की भावना लिए विश्वनाथ जी की विचारधारा की विश्व पताका लहरा रहे हैं। आज मैं आपसे और क्या कहूं, बस यही कि ये कारवां यूं ही चलता रहे, हर साल, हर मास, हर हफ्ते, हर दिन। गुणवत्तापूर्ण शिक्षा और विश्व शांति को समर्पित मैं आप सभी का आपका अपना माई।
On Biotech and Healthcare, a company founded on the belief of providing stable, sustainable, and scalable diagnostic tools and solutions. Operon Biotech intends to bring a portfolio of point-of-care tests, hematology, and healthcare products to the Indian market, more so in the field of coagulation. I call upon Mr. Afsar Sharif, CEO Operon Biotech, to address the audience.
Hi there. Firstly, thank you for the kind introduction. A huge congratulations to Maimar Medical College, the Department of Pathology, for organizing this amazing event of CME on coagulation. Coagulation, a subject that is often neglected, given less importance. So thank you for providing me this stage and opportunity to talk in this context. Welcome to the audience. I'm sure the given expert and eminent speakers, those who have graced the CME event, I'm sure we are. I'm very confident that we are going to take deep insights on this important subject, and also key takeaway message when we end this CME event. I think there is a paucity of time, and I'll have to be very succinct and be very crisp in my discussions. I cannot be comprehensive here. So the tagline, composite coagulation experts, says a lot about our company. As an entrepreneur and as a professional, in my professional career as a product manager, coagulation has been a mainstay throughout my journey. When I decided to embark on the professional journey as an entrepreneur, I decided that it has to be a coagulation first and customer first company. And when I look back to the products today after 17 years of entrepreneurial journey, I think I've done justice to that. Without wasting much time, I'll move on to the subject. But what sets apart our company to the peer companies in this industry is our undivided focus in the field of coagulation. The industry, the companies that lead the industry have coagulation as just an add-on product to complete the portfolio of products, and most of the time the coagulation analyzer is given free of cost. I'm not talking of labs like Ruby Hall Clinic or Sayadri or Maimar also. I'm talking of the lower tier labs where when the customer negotiates a biochemistry or a hematology or a CLIA or a culture instrument, coagulation is just given to us free of cost. On the contrary, when you see in our company, if you remove coagulation, we have nothing to offer. So this undivided focus has given us that push to address the problems that small labs, the lower tier labs, face on a day-to-day basis. The problems are enormous, be it in testing and reporting. And when I say enormous, it's still an understatement. So next slide, please. I can only move. Okay. So introduction is done. So the first product that I would like to talk, there are a lot of products, but I've chosen only few, keeping the timings in mind. The POC, point of care, brings in a lot of convenience. We all know that. Just a simple finger prick sample, and the results are out there in minutes. The flip side of a point of care is always the cost. It's normally expensive, but it brings in a lot of convenience, and at times it can be life-saving. For example, in the PPH, postpartum hemorrhage, or the obstetric coagulopathy, the fibrinogen levels, they drop very fast. And if anesthetists have the fibrinogen value handy, quick, which can give fibrinogen value easily, so the infusion, and the fibrinogen levels are stable, the infusion can almost be avoided. So at times it can be life-saving. So we have two variants in POC. One is a instrument for self-testing. Patients who are on anticoagulants, warfarin. So it brings in a lot of convenience. They still get a lab quality reports. The patient can test their INR values at the convenience of being at home. If anybody have used a glucometer, it just works on the same principle. Each strip is individually packed, as you can see in the center, and they have to just break open the strip, insert it in the device, and then add a drop of sample, and the results are out. So we have a professional model which can give PT, APTT, and fibrinogen. We have been doing this product from past 13 plus years with thousands of happy users, and even today we are the first Indian company to offer fibrinogen on a POC platform. A PT is basically done for evaluating the extrinsic pathway and vitamin K dependent factors. That is 1972 is easy way to remember the vitamin K dependent factors, and C and S. Also to understand the unexplained bleeding and manage liver disease. APTT is the second most important coagulation parameter asked in the laboratory for intrinsic factor deficiency, evaluating them, and for lupus anticoagulation testing, important for maternal health, and anticoagulant monitoring, that's heparin. Fibrinogen, either the absence of fibrinogen or low quantity of fibrinogen or dysfunctional fibrinogen can be estimated by a simple finger prick sample. Fibrinogen has an extended advantages during liver disease and DIC. The use cases are trauma, emergency stroke clinics, hemophilia clinics, of course, patient who are on anticoagulation for self-testing, and perioperative hemostasis management in cardiothoracic setup. Our another startup wing called Defined by Innovations, which we started in the peak of COVID, we developed the first Indian-made, completely indigenous, semi-automated coagulation analyzer. Today it is the most affordable coagulation analyzer system. We have a patent technology for this. It is designed for small labs to deliver the regular PT, ABTT, and also the special investigations like factor assess, lupus anticoagulant, and thrombotic panel. We have single and double channel variants. We have more than 300 users within the 1 year of launch. We launched this in last year, and we also exporting this product to the world. The entry-level automation, we have many models, but one stands out in our list, that's XL1000C. We have more than 150 happy users in India, 100 being in Karnataka alone. What automation brings is, you don't have to worry about the mixing of the reagent or keeping the reagent at a certain temperature because it has onboard refrigeration. You also don't have to worry about duplicating the test or keeping the tests in memory. The quality control aspects is all, maintained by the system itself. The tedious calibrations, like when you do fibrinogen or factor assays, the instrument does an automatic calibration without your manual intervention. So we have a holistic approach when it comes to coagulation. We just don't give hardware, we back it with qualities, technical support and service, and we give performance matched reagents. So in totality, we offer the product. This is the most affordable automation in India today, and every result that this instrument gives, it generates a curve. It will be very useful for a user to understand the result, why it is abnormal. So it's a simple automation with 6 sample positions, suitable for sample workload of 50 samples per day, less than 50 samples per day. It can accommodate primary tubes. It has LIS feature. It could do routine to special assays, and it offers testing in optical chromogenic turbidimetry and nephrometric principles. Extensive quality control with Westgard charts for data acceptance and rejection, and unlimited data results which could be recalled by ID or name. So there's a whole lot of reagents that we offer along with the instrument, including the routines and special assays. So thank you. Any questions? Otherwise, I'll end my talk. Thank you so much for your attention.
Thank you, sir. If anybody has any question and answers, you can meet sir after the session over tea and can clarify your queries. Now I request our HOD, Dr. Smita Bhide ma'am, to present a token of appreciation to Mr. Sharif. At the outset of the CME proceedings, I request Smita ma'am to felicitate our MMC observer, Dr. Gopal Ghare sir, Professor and HOD OBGY, D.Y. Patil Medical College, Ambi. I request the dignitaries to occupy their seats on the dais as we move on to the inauguration program. Respected eminent speakers for today's CME, Dr. Anjali Kelkar, Laboratory Director and HOD Pathology, Ruby Hall Clinic, Pune. Dr. Rajesh Fatale, Laboratory in Charge, Hematology Lab, Sahyadri Hospitals, Pune. Dr. Gopal Ghare sir, MMC Observer for today's CME. Dr. Deepa Nair, Principal, Maima Medical College. Dr. Darpan Maheshgari, Medical Superintendent, Dr. BSTR Hospital. Dr. Smita Bhide, HOD Pathology. Dr. Gauri Medkar, Professor, Department of Pathology. And dear delegates, as is our tradition, we will begin today's program with the World Peace Prayer, a humble invocation for harmony, compassion, and unity among all beings.
नमो दीयाद्या वेद प्रतिपाद्या जय जय स्वसंवेद्या सूचि गणेषु सकलार्थमति प्रकाशो मणे निवृत्तिदासु अवधारि बोधि गुरुर्ब्रह्मा गुरुर्विष्णु गुरुर्देवो महेश्वरः गुरु साक्षात् परब्रह्मा तस्मै श्री गुरवे नमः। पूर्णमदः पूर्णमिदं पूर्णात् पूर्णमुदच्यते पूर्णस्य पूर्णमादाय पूर्णमेवावशिष्यते। ॐ शान्ति शान्ति शान्तिः। हरि ईशावास्यमिदं सर्वं यत्किञ्च जगत्यां जगत् तेन त्यक्तेन भुञ्जीथा मा गुध कस्यचिद्धनम्। ॐ भूर्भुवस्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो न प्रचोदयात्। सर्वेऽपि सुखिनः सन्तु सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखमाप्नुयात्। द्यौ शान्तिः अन्तरिक्षशान्तिः पृथिवीशान्तिः आपशान्तिः औषधयशान्तिः वनस्पतयशान्तिः विश्वेदेवाशान्तिः ब्रह्मशान्तिः सर्वशान्तिः शान्तिरेव शान्तिः सामा शान्तिरेधि। ॐ शान्ति शान्ति शान्तिः।
I request the dignitaries to proceed for lighting the auspicious beginning of today's program. today's CME on coagulation in clinical practice, expert insights, aligns seamlessly with the 2025 International Pathology Day theme, the Global Pathology Workforce. This theme celebrates the unsung heroes of healthcare, the pathologists, laboratory scientists, and technicians whose expertise forms the backbone of clinical decision-making across the globe. In clinical practice, coagulation studies serves as a diagnostic compass. They help us navigate complex presentations, whether it's unexplained bleeding, thrombotic events, or perioperative risk management. These tests guide therapeutic decisions, monitor anticoagulant therapy, and provide critical insights into systemic diseases. Behind every PT, APTT, D-dimer, or fibrinogen result is a skilled pathology team ensuring accuracy, reliability, and timely reporting. Their work enables clinicians to act with confidence, saving lives and improving outcomes. In a world facing workforce shortages and rising healthcare demands, recognizing and strengthening this global pathology network is more important than ever. As we explore the clinical applications of coagulation testing today, let us also honor the global pathology workforce that makes this possible quietly, expertly, and relentlessly. I call upon our HOD, Dr. Smita Bide ma'am, to kindly deliver the opening address.
Good afternoon, distinguished speakers, esteemed colleagues, and dear students. It is with immense pleasure I welcome you all for this CME on coagulation in clinical practice expert insights organized by Department of Pathology on the occasion of International Pathology Day 2025. Each year, International Pathology Day is celebrated on second Wednesday of November. This year, it will be celebrated on 12th November, that is today. International Pathology Day offers us an opportunity to reflect on our profession and the quiet yet powerful impact of pathology on patient care. The theme for this year is the Global Pathology Workforce, which highlights on tackling workforce shortages, use of digital pathology, standardized trainings, and improving global health equity. Today's CME focuses on one of the most critical and dynamic areas in hematology, that is coagulation. From trauma care to oncology, obstetrics to infectious diseases, the ability to interpret and manage coagulation profiles is vital across specialties. We are honored to host distinguished speakers, Dr. Anjali Kelkar Madam, Lab Director and HOD Pathology, Ruby Hall Clinic, Pune, Dr. Rajesh Fatale, Consultant Pathologist at Sahyadri Hospital, Pune, and our own faculty, Dr. Gauri Metkar, Professor Pathology, whose expertise will enrich our understanding of coagulation diagnostics and its clinical implications. I extend my heartfelt gratitude to all the speakers for joining us today and sharing their knowledge. This CME brings together expert insights that will help us to bridge the gap between laboratory findings and clinical actions, ensuring that our patients receive timely and evidence-based care. I am thankful to our principal, Dr. Deepa Nair Madam, MS, Dr. Darpan Mahesh Gauri Sir, and MMC Observer, Dr. Gopal Ghare Sir, for gracing the occasion. Once again, welcome to this CME. I wish you all an enriching and inspiring day ahead. Thank you.
Thank you, Madam, for those insightful opening remarks and for setting the context of today's program. Now I invite our respected principal, Dr. Deepa Nair, to share her thoughts with us.
A very good afternoon to respected dignitaries on the dais and off the dais, and a warm welcome to our guest speakers, Dr. Anjali Kalkar ma'am, Dr. Rajesh Padale sir, and MMC Observer, Dr. Gopal Ghare sir. First of all, congratulate Department of Pathology for organizing a CME on such a relevant topic. And we know that coagulation is a dynamic process, and the understanding of the coagulation has evolved over these recent years. And knowledge about the update of coagulation is important because it is constantly evolving, whether it is the new research, new therapeutic or the diagnostic tool or the therapeutic agents. So staying current, it's very important. It's important for better patient care, proper diagnosis, and managing the outcome for the betterment of the patients suffering from the bleeding or coagulation disorders. Hope the CME provides an enriching learning experience to the participants. I'm not extending much, and let's hear from the experts. And best wishes for the success of the CME. Thank you.
Thank you, ma'am, for your words of guidance and inspiration. Thank you, dignitaries. I request you to kindly take your place in the audience. Let us now dive into the fascinating science behind the clot, a process that protects life by stopping bleeding, yet possesses challenges when it goes wrong. Together, we will explore how platelets, proteins, and fibrin weave this delicate balance and how disorders of coagulation can disrupt it. I now call upon Dr. Harsha Dangre to kindly take over the academic session. Thank you.
Thank you, ma'am. Good afternoon, everyone. A very warm welcome to all present. We are pleased to begin today's CME program with our first session. We look forward to an engaging and insightful academic journey ahead. So I am delighted to extend a warm invitation to our esteemed chairpersons as we commence the first session of our CME program. Dr. Sushma Sharma, Professor, Department of OBGY, and Dr. Rajendra Zupe, Professor, Department of Pathology, kindly take your seats on the dais. Now I invite our first speaker, our very own Dr. Gauri Medkar, Professor Pathology, to present her talk. So before we begin, I would like to request Dr. Sushma Sharma ma'am to introduce Dr. Gauri Medkar.
Introduce our very own Dr. Gauri Medkar, who is professor in the Department of Pathology, and she is the CCL in charge on the side of the Department of Pathology also. She has done her undergraduate from GMC Nagpur, and she has done her post-graduation from TNMC Mumbai. She has had a professional training in lab quality management, cervical pathology, and IHC. And of course, she has more than a decade, almost 15 years experience in both hematology, histopathology, and medical education. She has worked as a consultant in Oncopath, and she has various publications in both national and international indexed journal. And may I add, she's always there to help us clinicians at any time of the day and hour on behalf of the Department of Pathology. So over to you, Dr. Gauri.
Thank you, ma'am, for that kind introduction. At the outset, I want to thank our Executive Director, respected Dr. Suchitra Nagre ma'am, and Professor and Head Pathology, Dr. Smita Bhide ma'am, for giving me the opportunity to speak in front of stalwarts of pathology, Dr. Fatale sir, Dr. Kekar madam, who have vast expertise in the field of hematology and coagulation. I really feel humbled to speak in front of you all. So I'll be discussing various aspects of automation in coagulation. But before we embark on that journey, let's first brush a few basics of coagulation. The utility of coagulation in clinical practice is immense. So coagulation studies, we all know, they are used for diagnosis of primary and secondary coagulopathies like hemophilias, secondary coagulopathies like liver disorders. They are used for monitoring anticoagulant treatment, both oral as well as parenteral. They are used for detection and monitoring of hypercoagulable states like primary thrombophilias and secondary thrombophilias like DVTs and DICs. And other uses of coagulation tests include their utility in quality control in blood bank for quality control of various components like cryoprecipitate. They are also used for secondary coagulopathies resulting from severe infections and septicemia. So we have seen the utility of D-dimer during COVID pandemic, which was vastly used for monitoring cytokine storm. They are also important part of managing obstetric complications, and they are also important in pre-anesthetic checkups. So coagulation studies have wide implication in clinical practice. So the coagulation tests are mainly divided into three categories, that is screening assays, specialized assays, and the assays for inhibitor and anticoagulant monitoring. So screening assays include commonly done assays like prothrombin time INR, APTT, thrombin time and fibrinogen. The specialized assays we can include D-dimers, fibrin degradation product assays, specific factor assays and lupus anticoagulant assays. So little bit about these tests. So prothrombin time and INR, this is the most commonly done coagulation assay. It detects the working of extrinsic and common pathways, especially the working of factor 7, and it is deranged in conditions like vitamin K deficiency, liver disorders, disseminated intravascular coagulation. It is prolonged in patients who are on warfarin therapy. Now this warfarin, its mechanism of action is it acts as vitamin K antagonist. That's why prothrombin time is utilized for monitoring warfarin treatment. Activated partial thromboplastin time, it detects the function of intrinsic and common pathways, and it is deranged in conditions like hemophilias, von Willebrand disease. It is used for monitoring heparin therapy. Heparin has the activity as antithrombin, and that's why APDT is used for monitoring heparin therapy. Thrombin time, it is actually a screening test for fibrinogen, which detects the final stage of coagulation cascade, that is conversion of fibrinogen to fibrin. So it basically detects the quantitative and qualitative defects in fibrinogen. It is also deranged in presence of fibrin inhibitors, hypofibrinogenemia, and also in patients who are on heparin therapy. So little bit about international normalized ratio. So we have seen that prothrombin time test results are never given alone. They are always with INR. So what is the need of this INR? So prothrombin time reagent, that is tissue factor, that is the composition of prothrombin reagent. So its sensitivity varies according to different manufacturers and different batches, and that can lead to variation in prothrombin results across the laboratories. So to standardize prothrombin testing, something called as international sensitivity index is introduced. So this is the comparison of tissue factor in a batch with the internationally standardized sample tissue factor sensitivity. So it is usually should be between 0.9 to 1.7, and INR is calculated using patient's prothrombin time, mean normal prothrombin time and international sensitivity index or ISI value. So specialized assays include factor 1 or fibrinogen assay. So what is the difference between thrombin time and fibrinogen assay? So thrombin time is basically a screening test for fibrinogen activity, whereas fibrinogen assays, they quantify functional fibrinogen. So that's why it is a specific quantitative test for fibrinogen. D-dimer and fibrin degradation product both detect the breakdown products of fibrin, and they are deranged whenever they are deranged or increased, they indicate increased risk of thrombosis like DVT, pulmonary embolism, stroke, or DIC. What is the difference between D-dimer and FDP? So D-dimer is a more specific test which detects the breakdown of cross-linked fibrin, whereas FDPs, they detect the breakdown of soluble fibrinogen, which is normally present in the blood, as well as non-cross-linked fibrin. So D-dimer is a more specific test for detection of fibrin fragmentation and abnormal clot formation. So D-dimer is commonly used, whereas FDP detection is not used commonly. Something about mixing studies. So whenever screening tests like prothrombin time or APTT are deranged, we want to know whether it is because of clotting factor defect or whether it is because of presence of some inhibitors of coagulation. Okay, so in this, the further testing for this is guided by mixing studies. So in this, what we do is we take patient's plasma, mix it with normal pooled plasma. So the proportion varies depending upon the test which has come abnormal, like 1:1 ratio in PT derangement, and APTT we need 4:1 ratio. We mix that and we check for clot formation time. So this can be checked immediately after mixing or after incubation for 1 to 2 hours. So if the clotting factor, clotting time is corrected after addition of normal pooled plasma, it indicates that there is deficiency of coagulation factors. If even after adding NPP it is not corrected, it indicates there is presence of some inhibitor, and this is a screening test which guides us for further analysis whether we want to go for specific factor assays or inhibitor assays. So it is not a diagnostic test, but it is a screening test. So these were the commonly done tests in coagulation. Now just like in any other laboratory test, for coagulation assays we have these three areas: pre-analytical, analytical, and post-analytical. Introduction of automation in all these three areas spatially affects the accuracy and turnaround time of coagulation studies. Now in all these phases, the sample which we collect from the patient, it goes through different areas like labeling of the sample, conveyance or transport of the sample, sample processing and analysis, and its storage and retrieval as required. So introduction of automation in this area, it enhances the accuracy of the results. So in the analytical phase, there are different steps, and depending on that, the diagnostic assays are divided. So in manual assays, the reagent preparation and mixing of sample and reagent is done manually, as well as the quality control is also manual. In semi-automated analyzers, the reagent mixing, sample preparation and is manual, whereas the clot detection is done by analyzer. And in automated system, everything is by automated systems. So this gives more accuracy and monitoring of the results. So advantages of manual test is mainly the beginning cost, like there is no analyzer cost, and also the space required is less. But there are many disadvantages, like it has poor precision and reproducibility because of subjective differences in techniques. The subjective clot detection is also there. So for coagulation studies, basically what we detect is endpoint, that is clot formation. So what is the time required for clot formation? That is detected in coagulation studies. So in manual assays, it is done by observation, and that can differ from one technician to other. Also, it can affect the factors like weak clot formation, lipemic or hemolyzed samples, etc. Increased turnaround time because these procedures are labor intensive and they have more repeatability, and we can do only one test at a time, whereas in automated system we can do batch testing. They are also highly susceptible for pre-analytical errors like mixing of sample and reagents, contamination and hemolysis. So because of all these problems, it is very difficult to standardize manual methods across the laboratories, and that's where the need of automation. So other factors which contribute to need of automation is increased workload, need for precision, reproducibility and speed of the results, improving turnaround time, integration with laboratory or hospital information systems. So only automated systems can be integrated with the software, that can't be done by manual systems. Then performance of different types of coagulation assays at the same time, enhanced quality control and traceability. So introduction of automation in coagulation is not going to decrease the work of technician or pathologist, but what it is going to do is the pathologist can focus on more complex problem solving, quality assurance and result interpretation. So automated coagulation analyzers, they are the foundation of modern hemostasis by giving rapid, standardized and reproducible assessment of hemostatic function by precise sample handling and advanced detection technologies. So there are mainly two types of system in automated coagulation assays, that is semi-automated and fully automated. In semi-automated system, as I told before, mainly the clot detection is done by the analyzer, but other steps are manual. Whereas in fully automated analyzers, they have very many features like random access of the sample or batch testing. So here we can see this is the sample area where you can process multiple samples at the same time. Onboard reagents. So reagents are in the machine itself, they are not outside the machine. So we can better maintain the temperature, pH, etc. of the reagent. The mixing of the sample and reagent is also done by the machine, which is automated for precise mixing, and QC automation can be achieved by this fully automated analyzers. So before we go for what are the exact steps of automation in different stages of coagulation analysis, the most important part, that is sample collection or pre-analytical area. So as laboratory personnel, we always emphasize on pre-analytical part of any laboratory test. So if the sample is not good, we are not going to get accurate result whatever high-end technology we use. So sample collection is the most important part in any laboratory test. More so for coagulation assays, because the coagulation factors are very sensitive, and if the sample is not collected properly, we are going to get erroneous results. So the points which we should consider are, we all know that the coagulation samples are collected in citrate vacutainer. Now many a times we have observed that the sample is of adequate quantity, all the norms are there, but still the sample is clotted. So when we went back, we came to know that the sample was first collected in EDTA vacutainer, and then it was transferred to citrate vacutainer, and that has led to erroneous results. So why, when the citrate vacutainer as well as EDTA vacutainer both are having anticoagulant, so why can't we use EDTA samples for coagulation studies? This is because sodium citrate, it causes reversible chelation of the calcium ions, and it also preserves the coagulation factors. Whereas EDTA, it causes irreversible chelation of the calcium ions, and it also causes damage to the sensitive coagulation factors. So we can never use EDTA sample for coagulation assays, and they should be primarily collected in the citrate vacutainers and not transferred from EDTA to citrate vacutainer. Another important factor is quantity. So the main aim here is to maintain the sample and anticoagulant ratio in the vacutainer. So if we feel that we are not able to take out the large quantity, say 2 ml of the sample, what we can do is we can use smaller vacuum which are widely available. In our setup also we have micro tenors which require very small quantity of the sample. So you all can make use of these micro tenors when you feel that you cannot collect the 2 ml of the sample or more. So these are specially useful in critical patients, hypovolemic patients, and in pediatric patients. Another important thing is underfilling and overfilling. So we always, not only for coagulation, this is a very common area, we always show this black mark. Okay, so this is very important. The sample has to be collected up to this mark, whatever may be the quantity. So if the vacuum tenor is small, it will give the mark accordingly. So you have to collect it up to this only. If it is underfilled, then it is going to cause dilution of the coagulation factors, and if it is overfilled, it is going to cause clotting. So this is very important, although a very small step, but very important for correct analysis. Mixing of the sample should not be vigorous, it should be done gently, and the sample which is drawn, the order of draw has to be followed, and it should be drawn in a single continuous flow without any interruption, and there should not be prolonged tourniquet application, because all these are going to affect the coagulation studies. The time from collection of the sample to analysis has to be maintained. Preferably it should be done within half an hour. If we feel that it is going to take more time, the sample should be stored and transported properly. So what is the role of automation in streamlining and smoothing all these processes so that we can get good results? So we can introduce barcoding system for correct identification of sample and to prevent mixing of the samples. For mixing or of the sample and anticoagulant, we can use these roller mixers which will ensure smooth mixing of the sample, and we can use conveyor belts for transport of the sample inside the laboratory as well as from clinical departments to lab. So automation in pre-analytical phase, it ensures the integrity of sample, correct identification of the sample in appropriate form, appropriate sorting, centrifugation, division, and distribution of the aliquots. In this regard, if the sample there is going to be delay in the transport of sample, what we can do is we can separate the plasma from the sample, make the aliquots, and these aliquots can be transported to the lab. Automation prevents the decapping, recapping of the sample, preventing hazards while handling of these samples. It facilitates the proper storage and retrieval of the samples. And because of automation, if there are any issues or problems in all this process, they will be alerted by the automated system. The automation in pre-analytical steps also helps us to easily identify and detect hemolyzed lipemic samples with inadequate quantity, samples which are not maintained at proper temperature. So with that we can prevent unnecessary rechecking and proper collection of the sample at time, and this will improve the turnaround time of the test. So coming to automation in pre-analytical phase, where there is sample and reagent preparation. So after collection of the sample, next step is preparation of the sample from citrate vacuum tenor. So for coagulation studies, I hope you know we need platelet poor plasma, which is retrieved by centrifugation. So ideally this plasma should have a platelet count of less than 10,000 per microliter. So we should do random quality checks of the samples to know that to ensure that this standard of platelet count is maintained in the patient's sample. Then comes the reagent preparation. So reagents of coagulation studies are also very sensitive to temperature and pH changes. So automation ensures that these are the onboard reagents. So reagents are brought to adequate temperature in the analyzer and not outside the system. So this ensures the correct temperature maintenance of the reagents. And next step is mixing of the sample and the reagent. So in semi-automated analyzers and in manual systems, what we do is we mix the samples manually, and this can result in pipetting errors and improper sampling mixing. So in automated system there is automated pipetting, so it ensures the correct mixing of the samples. The next step, that is the important step which determines the derangement of any coagulation assays, so that is endpoint or clot detection. So in manual methods, as I told, it is done by visual observation, whereas in automated system it is done by using advanced techniques like optical or photo-optical methods, mechanical methods, chromogenic assays and immunologic assays. So in optical methods, basically what we do is a light is passed through the sample reagent mixture and change in the transmission of light is detected. The problem with this system is if the sample is turbid, otherwise like lipemic or hemolyzed sample, then these assays can give erroneous results. Most robust system is mechanical or electromechanical detection. So these systems, they detect the physical change in the sample because of clot formation. So the sample which is previously in a liquid phase, when it gets converted to viscous phase because of clot formation, that is directly detected in this system. So there are different methods used like moving probe method, moving wire or magneto-elastic sensors and magnetic bead method. So moving probe method, in this there are two main components. One is cup which is having sample and reagent mixture and a probe. So either of these is rotating, either the probe is rotating or the cup is rotating, and this rotation results in formation of the clot. So because of clot formation, there is change in the physical characteristics of the reagent sample mixture, and that is detected by the sensors. This system is very robust because it gives the formation of the whole clotting process and afterwards also the fibrinolysis in a real time. So right from the starting of clot formation, the strengthening of the clot and then fibrinolysis, the whole process is detected in real time and it is given out in a graphical presentation like that. So R is a reaction time, which is the first significant clot formation, then achievement of a certain firmness in the clot, then maximum amplitude where the clot of maximum strength is formed, and after 30 minutes the fibrinolysis percentage is also analyzed. So all this information is given out in a graphical presentation, and when there is derangement we get these variations in the normal graph. So this is the normal clotting process, but if there are variations we get different types of graphs. So these are useful for detection of both hemorrhagic coagulopathies as well as thrombotic coagulopathies. Other methods use moving wire or magneto-elastic sensors or magnetic beads. So these mechanical methods of clot detection, they are very robust because they are not affected by turbidities and are useful in difficult to test samples. For specialized assays, we can use chromogenic assays which give the detection by change in color and used for specific factor assays, or immunologic assays which are used for D-dimer or fibrin degradation product assays. So that was about the automation in analytical phase. Now coming to post-analytical phase. Now we have seen that when there is manual typing, we have to type one report at a time, and there are so many typing errors and communication errors. So all these errors can be minimized by laboratory or hospital information system, where the results from the machine are directly transferred to the software, removing the typing error and improving turnaround time. So there are many other advantages of automation in post-analytical phase, like better data management, reporting and visualization, streaming of lab workflows, tracking of the sample right from collection to analysis, inventory and equipment management, sample tracking and quality checks, data confidentiality, security and compliance, and streamlining of overall lab workflow. So laboratory information system is an integral part of modern laboratories. So, introduction of automation in coagulation has a significant clinical impact. It improves anticoagulant monitoring and patient safety. The results can be standardized across laboratories, and that's why they are very critical for monitoring or treatment of DICs, massive transfusion, and thrombosis management. The main limitations in automations are always the cost required for installation and reagents and maintenance cost. Sometimes the space required is also more. The technical expertise required is also a little bit more, but obviously the advantages of automation definitely outweigh all these limitations. So future trends include use of hybrid methods for clot detection, advanced quality sensors for preventing erroneous results, and pre-analytical sample integrity check. So before starting the analysis, we can check the integrity of sample and advise for recollection of the sample. Intelligent reflex testing. So if there is any critical result, the machine can reflexly repeat the result to ensure the correct output of the result. AI-based auto-validation systems, integrated hemostatic stasis workplace. So basically the large centers, they can integrate multiple coagulation analyzers to increase the throughput and seamless sample routing. Real-time monitoring, so that is important in patients like DIC to know whether the patient, when the patient is going into DIC, and after treatment whether the patient is responding to the treatment or not. So to summarize, automation has transformed coagulation testing through accuracy and efficiency. It is essential part of modern laboratory medicine. In spite of any advanced automation, pathologists always play a key role in result interpretation as well as validation of the test. And in future, we can have fully AI integrated coagulation labs, which will basically improve the efficacy of coagulation. These are the references. With this, I take this opportunity to inform that we are in the process of full automation in coagulation in our institute, with the addition of many specialized assays like specific factor assays, in addition to PT, APTT, D-dimer, which we are currently doing. So the details of all these we will be giving out soon to all the departments, and we expect a good response from all the clinical departments for increasing our expertise and utility of automation. Thank you.
Very nice talk. We can take one or two questions. If anybody has any questions.
The first few slides were actually for the benefit of postgraduate students, so that they will maintain the quality of samples they are sending for coagulation assays.
As a clinician, the only question that remains is, is the accuracy in any way affected with so much of automation? because sometimes there have been certain tests in the past. Of course, I know with what rapidity technology is advancing. So, will this automation in any way affect the accuracy? Is the only concern as a clinician.
Actually, the benefit of automation is improving accuracy, because we are, especially in coagulation assays where they are very sensitive, and if we do the mixing steps or reagent sample preparation steps manually, they are going to introduce lot of manual errors. In automated system, we can maintain the temperature, pH of the reagents as well as sample. The pipetting or mixing of the sample is done by automated system. So accuracy is actually going to improve.
Thank you. That's
Thank you.
Thank you for an excellent talk, Dr. Gauri, and I hope everybody has noted all the very, 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 which she said, important for sample collection.
So we are truly grateful for your insightful presentation and updates on automation in coagulation, Gauri ma'am. I now invite our chairpersons to felicitate Dr. Gauri Medkar. Thank you, ma'am. Thank you, sir. Now we are moving to our next session. It is my pleasure to now invite our second speaker, the dynamic and well-known hematopathologist, Dr. Anjali Kelkar ma'am, to take the stage. I request Dr. Zope sir to kindly introduce our speaker.
I am honored to introduce eminent guest speaker, Dr. Anjali Kelkar Madam, who is consultant in diagnostic hematopathology. She has 30 years experience in the field and held key positions in prominent institutes in Pune. Madam has received training at Royal Free Hospital, London, UK, and CMC Vellore. She has done prestigious Fimer Fellowship in medical education. She has done general management in healthcare education from IIM Bangalore. Madam is NABL and NABS assessor. Presently, Madam is Director Lab Services at Ruby Hall Clinic Group of Hospitals, Pune. Dr. Anjali Kelkar, Madam's expertise and contribution in the field of hematopathology has been widely recognized, and we are privileged to have her and share her insights with us today. We look forward for engaging and enlightening sessions. Welcome, Dr. Anjali Kelkar, ma'am.
Thank you. Thank you so much. It is very, it's a great experience. I'm feeling those all positive vibes among all the friends, and extremely thankful for giving me this opportunity, Dr. Bhide, madam, and organizers and Department of Pathology. So we have heard now today so much already. Right, so it's a difficult task in front of me, and I'm sure in front of Dr. Rajesh also, to further elaborate all these things. But let me take this opportunity to take you through this case-based approach to the coagulation disorders. Maybe that will make the topic of coagulation, which I usually say that it's an orphan subject, nobody likes coagulation, and that is how the progress has been, the way it has been so far. But it's a very, very interesting subject, and all of us, we think, the first thing which comes to our mind when we say bleeding disorder or hemophilia, we think about the royal family, right? And that disease actually changed the history, if I'm not wrong. But to tell you very honestly, this is a disease which affects all the classes. This is one example I usually give. This was way back when I was associated with KM Hospital, and this little child presented to us in casualty. He had just had a tongue bite. He had bitten his tongue, and with that he landed up with such a severe bleeding that he was very sick. We were establishing the laboratories in KM at that time, and we could make the diagnosis. He turned out to be factor VIII deficiency, and then later on he visited us also. And this is all about coagulation. You have to be so prepared and so confident and so accurate and precise that you are actually able to save lives when it comes to that. Therefore, the laboratory plays such a crucial role in the management of coagulation. This is the way we look at coagulation, management of coagulation. Basically, it's not individual person's job, although the laboratories play a great role and clinicians are there. Apart from that, you need money, you need all those NGOs. Patient himself has to be very engaged. And of course, there is role of nurses, counselors, physiotherapists, and so many more people. So this is the team effort that goes into management of these patients. I'm not going to go into the details of this. I think you all know this, and whatever you didn't know, Dr. Gauri Madam has told you already. But yes, so all the steps of hemostasis, they are important to remember, because the way the patients would present to us, it differs according to which of the components was defective or absent or involved. So typically we will think of vessel walls, platelets, coagulation factors, and we think whether it is a secondary defect or primary defect, like that. And to achieve a good hemostasis or efficient hemostasis, all this has to, there has to be a very efficient play among all these factors. So there can be so many things which can go wrong. There can be so many tricks which are played by all these components. But typically we can identify, we can start thinking about what could be the defect based on the presentation. We'll shortly come to that. So just to take you through vascular disorder, platelet disorders, not to forget von Willebrand's disease. If there are PGs among the crowd, you can give an answer as to which is the commonest of the bleeding disorders. Is it hemophilia? Is it thrombocytopenia? What is it? Anyone? It is actually type 1 von Willebrand's disease, which is commonest of the bleeding disorders. Most of them, they would not present to you, so you may not know, right? And of course, there are these hemophilias and other coagulation disorders, including the acquired disorders. So this is what we know, right? We want to think of coagulation pathway in this manner, something intrinsic, extrinsic, so on and so forth. I'll try and play this video here.
The first platelets arrive to start sealing the wound.
The voice is also playing.
Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A in combination with 5A activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot.
Right. So yeah, so this is what our understanding is, and there have been theories which don't exactly contrast, but they are different theories, and people say that this is not something which exactly happens in the body. There are no different distinct pathways, because if that was true, then the hemophiliacs would not bleed, right? Because then the rest of the thing will take care of that. So therefore, there has been literature that this is not physiological, and what is put forward by since some years is called something called as TFPI theory, that is tissue factor pathway inhibitor pathway. So there is something called as this inhibitor. So immediately after a small amount of thrombin is generated, in that little time, this TFPI blocks this pathway. Okay, and what further happens is all the further steps are actually initiated by that little amount of thrombin which is generated. Okay, and therefore the other factors, factor 8, 9 and all that further cascade happens only because of this thrombin which is generated at the first go. And of course we know the role of von Willebrand factor, and then the fibrin turning into from monomers to polymers and getting stabilized by factor 13. And of course there are roles of other natural anticoagulants which are also governed by thrombin. So all that is not very straightforward, but it's quite complex, and this theory stands now because, and of course there is role of calcium, because that explains most of the bleeding episodes that a hemophiliac would experience. Okay, there is fibrinolytic system which plays a role of controlling the amount of thrombus that is generated. There are plasminogen activators and inhibitors, and then there are these degradation products, and the role of fibrinolytic. This lecture is not for that, so we will go into that at some other time. So coming to this approach, why all this background was essential to understand how we approach these patients. So what all things which are important are, first of all, history. It will tell us how the inheritance was and how severe the disorder you are looking at. Then the clinical findings, of course, from where the patient is bleeding, what are the symptoms. Then what about the routine laboratory tests? Based on that, we go to the specialty investigations, the role of quality control, and then clinical correlation cannot be overemphasized. So what are the common presentations? Bleeding from the mucocutaneous areas such as bleeding from nose, gums, etc. And there could be joint bleeds, muscle bleeds also. And there could be excessive bleeding tendency also. So I think most of you must have experienced this, that patient goes for simple dental extraction and the bleeding doesn't stop, and then they are investigated, or post-surgical there is no stoppage of bleeding, etc. Then we also know that there are post-vaccination hematomas. The severe disorders, they would present early in life. Femoral puncture hematomas, I don't know how many of you have come across, but I'm sure the pediatricians, neonatologists and OBGY people know this, because there is nothing against which you can give a pressure to the femoral vessels. And so if the patient has a bleeding tendency, the neonates, they land up with a very big hematomas. And there is something which is accidental detection of an abnormal test. Now, how much importance is to be given to that is a separate topic for debate, but yes, it can lead you to probable bleeders. I hope it is visible, appreciable. I don't know how it's working. Anyways, you can see that on the left hand side you can see the skin bleed, and these two are classical examples of, anybody from the PGs? Yeah, these two pictures? Can you guess? They would go to orthopedic people, and orthopedics may want to, aspirate. But yeah, they are that, yes. So they are severe hemophiliacs, unfortunately. Now, what all history you would want to know is basically what was the onset and what was the site of bleeding. So onset will tell you how severe, again, is a disorder. More severe, it will present more early in life, okay? So umbilical cord bleeds typically go with factor 13 and factor 1 deficiency. Infants, they would present to you with severe deficiencies. And for example, there is an adolescent female who is presenting to you now with menorrhagia, then you can think of some mild factor and von Willebrand factor deficiencies. Bleeding site, as I was saying, mucocutaneous would go with platelets and von Willebrand, and joint muscle bleeds, they would go with factor deficiencies, okay? And if there is a known hemophiliac and they bleed from unusual site, you will always think of a additional cause, okay? And you have to know the history, because otherwise you won't be able to correlate the lab results, okay? If you are getting a very mild result or a very severe result and the presentation is not like that, then you have to go revisit what has gone wrong or right. Further in the history, any history of surgeries in the past, whether there were any transfusions, whether there were any factor infusions, and trust me, patients give you the exact history, which factor was infused, and what you have to ask is whether the bleeding, did it respond to whatever was given. That's a very crucial point in your history. And then all of us know the inheritance. Hemophiliacs, they run as X-linked, yeah, right. And von Willebrands will have autosomal dominant or recessive inheritance. And then the clinical examination, you have to know even if you are sitting in the laboratory, please make it a habit of sending your PGs or visiting yourselves in the wards and seeing the patient and finding out what exactly is happening with that patient who is bleeding. Then some of the very important points about any coagulation lab is you cannot suddenly start doing a test of coagulation. You have to basically have so much of proper infrastructure, and you have to develop that habit. I mean, you have to get into the practice of making it routine practice. Otherwise, these tests are not like biochemistry. Previously, they were treated in many of the labs like a biochemistry test, and that is how I think madam's question also from the past experiences, that people would not understand the nature of the sample correctly and etc. Okay, and pre-transfusion sample and quality control hold a very strong position. Okay, so this is from my previous days when we used to actually take sample using syringe and needle, and then we had to use something called as two syringe technique. Now we use those vacuum tubes. There is no question of using those needles for so many various reasons, but these are the important things in that. And but still, if there is somebody in this world who are using syringe technique, then this is the technique, because the first syringe you would always discard, and then the second syringe sample to avoid the tissue factor and so many other contaminants and etc. Correction for hematocrit, it is widely available, it is freely available on the net. So if you have a very high hematocrit patient, then, but again, my question is, how will you adjust that citrate volume in your vacuum tube? You know how much is to be taken out, right? But then how will you take it out? Any ideas? It's a vacuum tube. What syringe you will use? You will use an insulin syringe. Okay. In my life, myself I have not done it. I didn't have to do it many times. But if at all you have to take out that little amount of citrate which is in the vacutainer, you will use the syringe which is insulin syringe. Okay. So it will not disrupt your volume vacuum also. Okay. So this is, I think, covered. And a few of the points is you have to be off your drugs which are antiplatelets, oral anticoagulants, etc. If you are collecting from IV line, then take due precautions. And there is so much of importance of time, temperature, avoiding trauma, and then visualizing, seeing your sample, and so many more things. You have to know your equipment, how sensitive they are. You have to know your reagents also. There is something called as internal quality control and external quality assurance. These two are very different things, and those two give you very different informations and a level of confidence. So please adopt to these good lab practices. What are these? Yeah, leukemias, myelomas, aplastic anemias. Do you think these patients will present with bleeding diathesis? They will, and therefore your basic CBC matters. Yeah, these are pictures of marrows and etc. But yes, these are the patients who will also present with bleeding, and you will have to do your basic things right. Now the basic equipment, again, I come from a very old time now, I think, because most of the laboratory work which I did in my previous institution organization, we did it, trust me, manually. We run the whole entire coagulation specialty lab manually, but yes, it needs an entirely dedicated manpower, and you yourself have to be 100% involved. And with the kind of sample load that some of the hospitals like ours also experience, it's impossible to run that way. But it's a very sturdy and stable technique if you take care of the basic things correct. Okay. So coagulometers, madam has shown you already, and still in my heart, apart from, in spite of any coagulation analyzer, I like my manual technique still the best. Anyways, that apart, what all tests you have to really do? Hemogram, you have to look at the platelets, whether the platelets are good, adequate in number, and whether are you suspecting any qualitative defect also. So what about bleeding time? Anybody, again, from the crowd of students, have you done bleeding time anytime? What was the method? I have written IV's method, but that method was the method that you used? Finger prick? Okay, all right. So the thing is that that will not actually give you any information, right? Those methods have been promoted, they are in the practice. I have even seen people putting clot on the slide and seeing whether it is, so all that is nonsense. It doesn't hold any science. There is no science behind it. If you really have to do clotting time, it is by Lee and White tube method, and you see it only for seeing the clot lysis or clot retraction. Okay, otherwise test of PT, APTT have replaced clotting time. And the history, if you have heard about bleeding score, yeah, so that is the most sensitive test actually to be implemented for whether patient will have any bleeding tendency. This test of bleeding time by finger prick is not good. If at all you have to do bleeding time, it is by IV's method. In our hospital, we do bleeding time by giving appointments. If we think it is required, then we say, yes, okay, we will perform a bleeding time on this patient. Otherwise, we say that bleeding time has no place. Okay, just understand these facts, because as again she was saying, the science has moved so much that people really need to keep pace with that. Factor 13 screen is again very important, because if all the tests are normal and the patient is having still bleeding symptoms, then 13 will most likely fetch an answer in that case. So this is something, if the screening tests are normal, what all you can still suspect. As I said, factor 13 deficiency, if you have included it in your coagulogram, well and good. Otherwise, do it if the tests are normal. And then some of the types of type 2 horn millibrand, type 1 millibrand, they will still present with normal coagulogram. Mild factor deficiencies will not be picked up. Some rare platelet disorders will still be there. So accordingly, you will do the or advise the further tests. This is something we have in our hospital, which is ROTEM, which again was demonstrated. Important thing about this is bleeding patients from obstetrics, liver transplant, so many other trauma, all those they need very, very rapid results. And this will give you results in 10 minutes. And then all the basic information is given to you in 10 minutes. I have written 20, but 20 is like the outer. And then the test can go on till 90 minutes. But within first that maximum half an hour, you get all the information that you need about the global hemostasis. PT and APDT are going to give you the information about, which is a static information at that time point. This is going to give you a global information which is dynamic. And this is entire coagulation process that you can understand. This is a cartridge and it's essentially a point of care, but it's a high end, so you have to just keep an easy access and make it available widely. A very little thing about total lab automation. So we could establish this, and out of the whole process, we haven't yet put the coagulation analyzer on the track of automation, because we thought that we still need more samples to justify that, and also the entire track might have become little slower. But the coagulation samples, they are analyzed through the middleware software. They are sorted out and they are centrifuged also online, and the technician just has to take the rack and put it in the analyzer. Rest of the things happens on the analyzer. So all the total lab automation components we could establish right now are these, and these are little small videos when we actually did this. So now we are almost 2 years down the line, and you can see these two, there are two robots which take care of all this. So samples are sorted, they are identified, they are already barcoded, they are centrifuged, and they are sent to the analyzers. So most of the people like that part, they want to come and watch that, samples moving through the track. But but the entire this entire process runs because there is a software called as middleware software, in which you define all the QC rules and everything. So coming to our cases, if only bleeding time is prolonged, then again this is for the PGs and of course for us, that you will think about running platelet function tests. And platelet function tests have evolved over a period of time, and you can see different kinds of tests I've tried to, but it's it's looking quite faint over there. But there is something called as Verify Now. There are something called as platelet function analyzers. Then of course impedance aggregometry, then viscoelastic testing, platelet activation, and all those studies by flow cytometry. So platelet function tests have really evolved over a period of time, and you can, it's a big topic by itself, and you can see that all the defects have the possible diagnosis with them. What if only PT is prolonged? You will think about factor 7 deficiency, provided that you have taken the history that there is no warfarin for this patient. And if only APTT is prolonged, then you will think of all those factor deficiencies, and accordingly you will do the correction studies, factor assays, inhibitor screening, etc. What if PT and APTT prolonged? Then all those common pathways, and accordingly you will do these studies. Case 1, I come up with a child who is 15 years old male, presented with post-traumatic nasal bleeding, no family history of bleeding disorder. What are the tests? CBC is normal, prothrombin time is normal, and APTT is deranged. Yeah, everybody agrees this is deranged. Control is 28 and test is 45, so it is deranged. And when we tried to correct it, it corrected to 30 seconds. That means it got corrected. Okay. So what is the likely diagnosis? And which of the tests would help you? Two things. Yeah, correct. So which test will you do? You will not do thrombin time, I am saying. Do you agree? Because thrombin time will be done only if both are deranged, right? Here only APTT is prolonged. So we will do correction studies. We will do factor. Why von Willebrand studies? Because the child is having mucocutaneous bleed. Okay. All right, so he is likely to be probably von Willebrand because there is no family history. Okay, so this is just to take you through that. 23 years old Primey, she is come for routine antenatal checkup. She gives history of heavy menses and she also gives history of nosebleeds. So hemoglobin is 9, okay, TLC, she is pregnant, platelets are also, something went wrong. Wait. No, that will be too much. Okay. All right, so we were here. Yeah, so look at her results now. PT is again normal. APTT is deranged. Yeah, it was corrected. Somebody was convinced that yes, bleeding time is required, so bleeding time was done. It was 12 minutes. So it was marginally prolonged. Yeah, by IV's method up to 10 minutes also you can take it like okay. Factor 8 was done for her and very appropriately von Willebrand factor was also done. So you see the similarity. That was a child. This is a lady who is a primey and she is giving history of all these kind of bleeding tendencies and her tests are abnormal and we have gotten a diagnosis. Okay. This is incidental. So von Willebrand's disease, there are 3 types and typically if it is a severe bleeding, severe type of von Willebrand's disease, that is type 3, then you will have bleeding time as well as the APTT prolonged. Why? Because von Willebrand factor has dual function. It has function in primary hemostasis and it protects factor 8. Okay? So von Willebrand. 18 years old female, she presented with left lower limb DVT. Okay, so do you think this has got something to do with bleeding disorders? Anything from the history? Yeah, she has thrombocytopenia. Yes, she has presented with DVT. There is some thrombocytopenia also, and her APTT is grossly deranged. What do you think it's happening with her? Correction studies we did. Would you say this is correction? No, so it was not corrected. That means what? It's an inhibitor. So what inhibitor will present like this? Anybody? Yeah, I'm giving you the clues. So what would be the likely diagnosis? And what would be your first investigation of choice? I am not asking all the investigations that you will do. I am asking which is your first investigation of choice. Okay. Some people are not allowed to give answers. Right. So why DRVVT? Yeah. For diagnosis of lupus anticoagulant, of course, but it is going to give you the thrombotic tendency. So there are guidelines which are now there and we have to really study them and follow them when we want to report these lupus anticoagulant or DRVVT results. And there has to be a time gap when you will repeat also. You will do all the tests because triple positivity is going to give you the information about high risk patients. So this is one of the he is a child, he is 18 years old female and he is having this heme arthrosis joint and he is presenting with these symptoms. The maternal uncle is giving history of similar. So where do you go from here? He is likely a hemophiliac. Yeah. So he gives history of this symptomatic relief with FFP and also whole blood he had received. So he gets little better with this. So do you think any clue from this? Do you think he could be hemophilia B, that is factor 9, which is a more stable factor and most of the blood banks, even if factor 8 may be compromised, factor 9 is usually there. So which tests do you think are justified in this patient? Out of these, factor SA, PT, APDT, correction, thrombin. So you will not do thrombin time again. Very simple. Okay, unless PT and APTT both are deranged, there is no place for thrombin time. Don't include it in your routine testing, right? Do it judiciously. Now, this was our dear friend from Hemophilia Society actually. He was a known case of hemophilia A. He presented with hematuria. So far, he had not presented to us with any spontaneous bleeding episodes, or he had not undergone any surgeries also in the past. But now he presents with hematuria. Okay. So what do you think is happening with him? Is his bleeding likely to be hemophilia? Could he have acquired anything against factor VIII antibodies? Could he have any local cause or a systemic cause? What is likely in this gentleman? Could be acquired, yeah, but he has so far not received, he has not been exposed to any factors. So, yeah. So actually, we did suspect that something else is going on for him, and very unfortunately he turned out to be renal cell carcinoma. When he was diagnosed, the malignancy had already spread. He could not be saved, but the big lesson over here is don't put all the blame on the existing disease which was there. There can always be something more, and patients will suffer if we don't diagnose them on time. So if the bleeding is not responding to factor replacement also in a known hemophiliac, you have tried that, always think of another cause, surgical cause for bleed, think of inhibitors, think of acquired defects. Okay. 10 years old female, she had a history of fall. She presented with IC bleed, and she also gives history of delayed wound healing. Any clues from this? Anything? Delayed wound healing. Further thing, her platelets are normal, her PT-APTT is normal. What is left when everything is normal? What have we not done here? Yes. So factor 13 plays a role in all this. It could be congenital or acquired. In this child, it is of course it is congenital. But there are many cases, many scenarios when you can get acquired factor 13 deficiency. And of course, there are tests commonly available is clot solubility, which is not very sensitive, but it's a very useful test for diagnosing or screening severe deficiencies. Okay. 68 years female, she presented with purpura and ecchymosis. Her TLC is little low, but her platelets are drastically low. Her autoimmune workup is negative. She is on some medications for arthritis. Her dengue is negative, and bone marrow study shows megakaryocytes adequate. There is no evidence of dysplasia. Straightforward, classical case of, yeah, very, very low platelets in the periphery and adequate or increased megakaryocytes in the marrow. Yes, great. So there are many causes of thrombocytopenia that we know, and immune thrombocytopenia also we know. So when do we typically land up in doing bone marrow studies? Or do ITPs really need bone marrow studies? Nowadays the treatment modalities are different, the management is different. So when do you need the bone marrow studies? They present like this, mucocutaneous bleeds, and etiology is sometimes very clear. In adults it's not very clear. Many times it's a diagnosis of exclusion. So if patient is elderly, or if there is no response to treatment, then you would need bone marrow studies. Okay. And of course, if the clinical picture is not clear, otherwise it's a straightforward diagnosis. 42 years old male, unhealing ankle wound, multiple thrombotic episodes. This is a very interesting case also. So CBC was normal. His PT, do you think it is deranged? Yeah. And APTT? So very correctly we did the thrombin time. What's happening at thrombin time? It is also deranged. Now there are thrombotic episodes. So what's going wrong in this patient? And he has again something related to unhealing wound. When we further studied him, we could not find any fibrinogen activity. We did the clot wet method for fibrinogen antigen, which gave us some value which was 290. That means it's okay. So the quantity of fibrinogen is good. D dimers are not detectable, and he has one brother who has similar lab values, although he is not suffering actually like him. So what do you think is happening here with fibrinogen? Anybody? Patient has thrombosis, fibrinogen activity is not there, fibrinogen antigen is there. So what it could be? Yes, so it's a dysfibrinogenemia. Okay, so in dysfibrinogenemia you will sometimes get bleeding, sometimes you would get thrombosis. So you have to be very alert as to what you are dealing with. And we could diagnose it because we could get the antigen, which we could get it by clot wet method. The functional assay did not give any results. Okay, so these are the combinations, qualitative, quantitative defects of fibrinogen, and they would present to you very interestingly. There are very good articles available out there in the literature which tackle various issues of handling these fibrinogen defects. So next case is 4 years old female presented in ER with acute onset bloody diarrhea, high grade fever, dehydration, decreased urine output. She has episodes of unresponsiveness, generalized seizures, hypotonia. Her creat is deranged. Urinary protein is there. There are RBCs also. Okay. Now look at her lab results. 6.2, 16,000, 41,000 platelets. Yeah, PT and APTT are normal. PBS shows schistocytes and LDH is raised. GI biofire told us that it's E. coli. What do you think it is happening? What's happening here? Okay, what are they called as? Yeah. Yes, so they are called as thrombotic microangiopathies. So there are microangiopathic hemolytic anemias. In children you would get this. So there are TTP and HUS, right? So there is this classical history where you are seeing a child landing up with HUS, okay? And schistocytes, so there are guidelines how you report the schistocytes and etc. So you have to adhere to those, identify the schistocytes correctly, and keep a serial follow-up of these patients. Very quickly on DIC, I am not going into the details of pathophysiology, nothing. I am sure you all have studied it lot more than me. And yeah, so what happens in DIC is there is this typically sepsis induced when the platelets are gathering around, and then you land up with PT, APTT, both deranged, thrombocytopenia, schistocytes, spherocytes. There is thrombosis of small vessels as well as bleeding, and then organ failure, finally leading to death. That is the overall scenario about that. Lots many clinical conditions associated with DIC. I just thought of covering it as part of the spectrum. So there is not a single test which can diagnose DIC, but it's a multitude of tests, and you have to have a high level of suspicion. There are scores which can tell you about the DIC, such as ISTH scores. Last case, I think, so this is not my case or any of the hospital's case. This is a published case, but it's a very interesting scenario. There is this boy, 7 years old, who had post-circumcision prolonged bleeding, and he was misdiagnosed as hemophilia A. And then there was history of epistaxis also, which was revealed later. And then PT, APTT both are deranged, corrected. Factor 8 is also low, and factor 5 is also low. So anybody who already knows this condition, there is this mutation which is classically associated with this condition. It's a combined factor 5 and 8 deficiency. Okay, it's not that factor 5 gene also wrong, abnormal and 8 also abnormal. It's not like that. It's a one mutation which gives results to this condition, which is both factor 5 and factor 8 are mildly low. Okay, now interestingly, he has two siblings. One sibling gives similar history and profile also similar, and second is little elder sister who has epistaxis and menorrhagia. So these people come to the lab, you find HepDT derange, you do the factor 8 and they are labeled as factor 8, which is a very common mistake. Or a sample is transported from this place to that place, the factor 8 is depleted and you diagnose factor 8. So all these misclassifications are very dangerous for the patient. So these children had consanguineously married parents and they had coagulation profiles normal. Okay, so both parents had those genes and so the children were the sufferers. So what is the importance of all this? We saw so much. So basically you won't be able to give correct factor, you won't be able to use correct support medications, and of course there are genetic implications. Okay, so therefore all this. And please remember that first child's case, I just showed you the photographs. So we are working for that. So coming to the end, take home message, the laboratory science and technology has evolved leaps and bounds by advances of IT and engineering. There is a progress in medicine, but software people and engineers, they have worked a lot for all those automation tracks and middleware and whatnot. Importance of history and clinical details while approaching patients cannot be overemphasized. Sound laboratory practices, sample integrity, attention to quality are extremely important, and systematic approach is necessary to decide the required investigations, as many tests are costly, they are time and labor intensive. So we cannot jump to the whole and entire coagulogram for each and every patient. With that, I really thank you from the bottom of my heart. This is us, our team at Ruby, and thanks a lot once again. Thank you.
Thank you, ma'am. It was an excellent presentation. Any questions from the audience?
Yeah, Madhu.
Macrophage activation syndrome or hemophagocytic, should it be counted under, it is a coagulation defect or it is acquired?
No, it's not a coagulation defect as such. So it will happen typically
Post-infections.
post-infection, and they are just engulfing the whole thing.
Okay.
So not as such coagulation factors
Okay.
are affected, but of
Because
course
they
if there is severe thrombocytopenia, the patients will bleed.
Yeah.
Yeah.
And we have to measure the fibrinogen and
Yeah, we have to
is
measure
low.
triglycerides and ferritin.
Ferritin. Yeah.
Any questions, please? No? Okay, we can move.
Thank you.
Thank you so much, ma'am. It was really a eye-opener even for clinicians. Only thing is, it's so mind-boggling, and you very correctly said that the dialogue between the clinicians and the pathologist in helping analyze what has gone wrong. So analysis of the result in the coagulogram, I think, remains the pathologist's forte. And it definitely helps us a lot in deciding the line of management. Thank you so much.
Thank you, ma'am, for that lucid talk. I now invite our chairpersons to felicitate Dr. Anjali Kerkar for her valuable contribution in today's CME. Thank you, ma'am. I request Dr. Smita Bide, Professor and Head, Pathology Department, to felicitate our chairpersons in appreciation of their guidance and support throughout this session. Thank you, ma'am. Thank you, sir. We now move to our third and final session of the day, which will be chaired by Dr. Madhu Bansode, Professor and Head, Department of Medicine, and Dr. Sachin Naik, sir, Professor and Head, Department of Surgery. Kindly take your chairs on the dais. We are honored to have such distinguished faculties to lead this final session of our CME. The last session will be conducted by Dr. Rajesh Fatale, sir. I request Dr. Chandras Gudbole, Associate Professor, Pathology Department, to kindly introduce our speaker.
I welcome Dr. Fatale sir on this stage, please. Sir is currently working as a head of hematology laboratory at the Sahyadri Specialty Hospitals. He has received specialty training in hemostasis, molecular biology, and quality management system. He is of course the lead assessor for NABL, and he has presented posters at various international conferences. To note the important ones are the APTT clot wave form analysis in ISH TM conference 2017 at Berlin, World Congress in Hemophilia in 2020, and ISTH in 2020. He has been involved in organizing various workshops in coagulation techniques. So I welcome Dr. Fatale sir once again and ask him to continue with the session. Thank you, sir.
Good afternoon, all. Delivering a talk or sharing my own experiences in medical college is definitely a challenging as well as an honorable task for me. And it's an opportunity for me to share my experiences. I'm not at all an academician. I'm actually a practicing pathologist. But the moment I joined Sahyadri, and that too with Dr. Shashikant Apte sir, Anjali ma'am will know that how meticulously he works and he makes us work. Particularly in the field of hemostasis, she already told that we have to be on our toes and we have to be practically involved in performing each and every test, and that's why even we are quite well trained to do the test manually. And As she already said, the manual tests are equally accurate if done properly. So that experience has brought me to stand up over here, and my special thanks to entire MIMER team, Dr. Smita Bede madam, Dr. Chandrahas sir, and special thanks to Dr. Sandhya Kulkarni madam. So with that, I'll be dealing with intricacies of PT and APDT. The stage is already set. The majority of the theoretical background is set, so I'm not going into the details of the theory part because I'm not at all an academician, so I won't go into the details. But yes, every practical or every report related issues, I will try to correlate with the theoretical background. Okay. So this is the area, this is the lab, wherein the building of the lab wherein we work. Yes, again, I'm fortunate that this cascade actually was not shown, even though it was mentioned by both the speakers, and it will be an integral part of each and every talk that will be delivered on coagulation. So all of you know about the extrinsic pathway and the intrinsic pathway. The test involved in the extrinsic pathway is the prothrombin time, and the test which represents the intrinsic pathway is the APDT. The test which actually represents the common pathway is the thrombin time. Okay. So as was told by Dr. Anjali madam, if this was the real fact, then the hemophilics would not have bled, or patients of factor 12 deficiency would also have bled. But we know that patients of factor 12 deficiency never bleed. That means there is some issue with this waterfall or cascade theory. And the scientists who actually postulated this, that is McFarlane and Oscar Retnoff, they knew this thing at that time. Because the picture, the patient is nobody else than John Higman, and the doctor who is taking the sample is Oscar Retnoff. And when the sample was collected on John Higman, his APDT was prolonged, but he never had any episode of bleeding. So they were knowing that this is not the real picture what happens inside the body. But they had actually postulated this by developing the reagents in such a manner that it will differentiate the intrinsic pathway from the extrinsic pathway. So PT will be correlating with the extrinsic pathway, and therein they have added the thromboplastin, wherein in the intrinsic pathway or the APDT, the thromboplastin was not added, only the phospholipids were added. So there itself they were knowing that this is true only for the laboratory part, not it actually, it will never be the true scenario in the body. So later on this cell-based theory came into the existence. The tissue factor pathway inhibitor, Dr. Anjali ma'am has already elaborated on this, and everything is revolves around the thrombin because of the thrombin burst, and everything is being. Now one more important thing is that the factor 13, which doesn't come into the picture till the formation of fibrin. So if there is factor 13 deficiency, you will expect that PT and APDT to be normal. But if there is fibrinogen deficiency, then there won't be any formation of clot. So PT and APDT and thrombin time will definitely be prolonged. So what are the expectations from PT and APDT? Okay. So the first and foremost expectation is pre-op evaluation. Okay. Now there can be a debate about the importance of PT and APDT as far as the pre-op evaluation is concerned, but that is not our part. Then diagnosis of bleeding disorders, the most common bleeding disorders, monitoring of treatment of bleeding disorders, monitoring of therapeutic agents like warfarin or heparin therapy. Then comes diagnosis of prothrombotic conditions, monitoring of quality of blood products, which is the most important part of late now. Most of the blood banks do need to maintain the quality control program. And PT ability is one of the integral part of that program also. So, along with that, I would just like to emphasize the mandatory components of the PT and APTT report. Okay, the first and foremost, of course, is the patient result. For PT, followed by MNPT, that is the mean normalized prothrombin time. We'll come to that, what it is. PT ratio, that means by patient and the MNPT ratio. ISI value of the reagent, that is a mandatory part. The INR value and the lab established reference interval. It has to be established by the lab on their own. A reference textbook document published reference interval is not accepted. PTT results, reports, the content should be patient results, PTT control value for the lab, and the lab established reference interval. These are the mandatory requirements for these reports. Without these, the report is incomplete. The mixing studies, in case of prolonged results, is desirable but not mandatory. But if the lab does these mixing studies, then the lab itself will be having some additional information about the prolonged results. Okay. Now coming to again the waterfall cascade theory. Now, since the surgeon is there with me as the chairperson, I would like to take this opportunity to ask him how many times the surgeons or the any person who is operating is advising PT and APTT as a part of pre-operative screening. Because we come across many times that either only PT is asked or only BTCT is asked or nobody is asking APTT for that matter.
Yeah, that's absolutely true. Most of the times we do not ask APTTs.
Yeah, right. Thank you. So of course, history plays the major role. Without history, there is nothing to go ahead with that. But if anybody is asking only prothrombin time, then the test which is being covering the PT test is covering only the extrinsic pathway. That is only the factor 7 and of course the common pathway. Rest all the factors which are there in the intrinsic pathway are left undiagnosed. Okay. So if you ask only for PT, then you are dealing with only with factor 7 and you are not at all evaluating the other factors. Same is true with only APTT. If it is asked, then only intrinsic pathway, factor 7 and all is not being asked. So it's always better to do PT as well as APTT as a part of pre-operative screening, so that you know the entire coagulation cascade, whether it is properly evaluated or not. If the results are normal, then you are sure, you are safe, you can go ahead with the surgery. Now coming to the cases. Now she is a 49-year-old lady, operated case of rheumatic heart disease. Patient post-operatively was started on oral anticoagulant, and the PT value after that oral anticoagulation was 28 seconds against a MNPT of 11.2, INR was 2.6. It was the desired INR, so patient was discharged. And the patient was asked to keep a follow-up with a weekly PT at the local place. Okay. So at the local lab, the PT was done. It was 20 seconds. So the local physician says it is less than the 28 value which was there at the time of discharge. So the dose of the oral anticoagulant is raised. Next week, the PT is still 25 only. It is again less than what it was at the time of discharge. So the dose was raised. And the third week, the PT is actually 41, not too much high, but patient is unconscious. Patient becomes unconscious, comes back to the hospital. Upon admission, the PT is 90 seconds. Against an MNPT of 11.2, INR is 8.9. So obviously there is some IC bleed. So now if you see, this is the at the time of discharge, these are the values which the local lab was doing. Upon inquiry with the lab, The ISI value of the reagent was 1.8, and if you see for 20, it was the INR was actually quite in the range of the discharge value. There was no need of any increase in the dosage, but just doing the PT has led to this disaster. So INR is a mandatory thing as far as the treatment of oral anticoagulation is concerned. INR is designed only for monitoring of oral anticoagulants, that is the vitamin K antagonist. Now, what are the contents of the PT reagents? It contains nothing but tissue factor along with coagulant phospholipids called as thromboplastin. There are various sources of the thromboplastin. Most preferred is human, that is like versus like, but rabbit brain, the recombinant technology, thromboplastins are there. The recombinant thromboplastins do have a stable ISI value, and there is little variation between the batches, so it is the most preferred in the current scenario. But rabbit brain also is equally a good source of thromboplastin. So your desirable ISI should be near to 1. So what is this ISI? Dr. Gauri has already mentioned about this. So this ISI is nothing but International Sensitivity Index. It is the quantitative measure. Particularly, it is the quantitative measure to assess the response of the PT system. Now, when PT system is mentioned, it is nothing but the person who is performing the test, the equipment on which the test is being performed, and the reagent which is being used for the test performance. So this is the PT system. Okay. So the responsiveness of the PT system to the defect induced by oral anticoagulant. So practically ISI and INR are required only for monitoring of the oral anticoagulant treatment. It may not be needed if there is factor deficiency. In absence of oral anticoagulation, it's actually not needed, but now it's a standard format of reporting, so it comes on its own. And now this is the traceability of the thromboplastin. The first and foremost, that is the first international reference thromboplastin. It was established way back in 1976, and it shows the tree of all these. That is the bovine thromboplastin, the rabbit thromboplastin, and the recombinant one. So the thromboplastin which you are using, by establishing the INR, you are actually traceable to the original international reference preparation, so that it minimizes the variation between the values of PT between the labs or between the different reagents. Now, when one has to choose a reagent for prothrombin time, the most suitable reagent will be ISI close to 1. ISI values between 1 to 1.4 definitely acceptable. 1.4 to 1.7 can be chosen if there are no other available reagents in your area, which may happen. But values above 1.7 should not be used, and the reason we have seen in the previous case. Okay. Now, animal or human source poses a definite hazard of the viral infections or the prions. So recombinant thromboplastins are being more and more used into the market now. Now, MNPT estimation, Dr. Gauri has already mentioned this, but the lab has to establish its own MNPT. And this is, in brief, the process for doing the MNPT estimation. Platelet poor plasma has to be prepared. And the geometric mean has to be calculated, not the arithmetic mean. This is actually more important when a sample size of more than 100 is being used. If a sample size of 20 or 30 individuals is used, then even an arithmetic mean and geometric mean are quite similar, in the similar range. Then you have to establish the SD of the values of the PT from the individual samples, and the plus to minus 2 range will be the reference interval for your own lab. So you have to establish, the lab has to establish all these things and then only do the interpretation of the results. So this is an example of the Excel sheet, how it can be used. Now, Let us come to these three cases. There is 28-year-old female, 49-year-old male, and 68-year-old male. PT values are prolonged. INR values are prolonged. Now, what information you gather from this? You never know why it is prolonged. So the first and foremost requirement is history. If there is history, now the first patient presents with history of menorrhagia. That means the patient has got some bleeding. So some bleeding disorder is there and the PT value is prolonged. Second patient is of decompensated liver disease. That means there is some liver dysfunction and the PT is raised because of low fibrinogen also and the what I can say rebalanced hemostasis in the DCLD. Third patient is BAP with just for the preoperative bleeding, a preoperative evaluation, and the patient's PT is prolonged. Now these three different cases are there. So unless and until you know the history, you won't be able to interpret what exactly the interpretation of the result is. Now if you come to these two cases, now same thing, we have to do the mixing studies. Now in both these cases, the mixing study shows there is complete correction, right? That means there is factor deficiency. And now we are dealing with prothrombin time. So the first and foremost will be factor 7, right? So we do the factor 7 of this 28-year-old female, it is 4.5, and for that adult it is 9.8. Now PT of this patient is 28.9 and PT of this patient is 41. So one will expect the factor 7 value of this elderly male less than the female, but it's actually reverse. And that is true in most of the rare bleeding disorders. Now, factor 7 deficiency is a rare bleeding disorder. Anjali ma'am already told you that 1 millibrand is the commonest, followed by hemophilia A and B. Rest all factor deficiencies are categorized as rare bleeding disorders, wherein the prolongation of the prothrombin time or the prolongation of the PT and APDT never correlates with the factor level. Right? So that's also equally true. So coming back to this case, this is a 2-year-old male case of cyanotic congenital heart disease, posted for open heart surgery. This is pre-op evaluation. Now if you see, hemoglobin is significantly increased, so the hematocrit is high, and which is quite expected for a baby of cyanotic congenital heart disease. PT is normal, APDT is prolonged. Any clues? Hemophilia? Anything else? 1 millibrand? Anything else? There is no history of bleeding. The patient is not a bleeder. So the patient's hematocrit, if you see, will definitely be high. Hemoglobin is 18. But now tell me, how many technicians will be knowing the CBC values of a sample who has come for PT-APDT? Then how will they know that this patient's sample has got a high hematocrit and do the correction? One simple thing is, look at the RBC column. So this is for the normal, this is for the anemic patient, and this is a polycythemia. Usually, if the hematocrit is somewhere around 45 to 50%, this should be a half of column. So every time the centrifugation is done, it is being visualized manually by the technologist. So they should actually inspect the RBC column, see how much volume of plasma is there, and if there is some doubt that the hematocrit may be high, then the technician can always go back, discuss with the consultant, see the CBC reports, and do this. Now, the trisodium citrate anticoagulant proportion 9:1 part is a designated proportion which is to be followed. So this proportion is being specifically made since it is a as Dr. Gauri has already told, trisodium citrate is a weak or reversible chelating agent of calcium ions. And all the clot-based assays are nothing but a process of recalcification. We are adding calcium ions into the test. So these calcium ions are actually starting the clotting process. Okay. So what happens in high hematocrit samples? The plasma volume is less, as is seen over here. The plasma volume is less as compared to this. So there are unused citrate molecules which will be there in the plasma. Those will consume the calcium ions from the calcium chloride which is added, and there will be inadequate calcium ions available for actual clotting time. That will increase the value of the APTT. Why not PT? PT also is a clotting process. PT also is a recalcification process. Then why PT is not prolonged? Only APTT is prolonged. The reason is PT is a specific test. PTT is a sensitive test. The reason being, a PT reagent is designed in such a manner that if in vivo, in the body, if one molecule of tissue factor is actually initiating the clotting cascade, the PT reagent will have thousands of molecules of thromboplastin. Okay, so it is never a sensitive test, because say suppose the value of PT is 11, and if you dilute the sample 10 times, you will expect the value to go to 110. But it doesn't happen like that. The value goes to 18, 19, 20, not more than that. It's because there are a lot of thromboplastin molecules available in the PT reagent which will help in normalizing the results of PT. But it is definitely sensitive to factor 7 deficiency only. It is a specific test for factor 7 deficiency. On the contrary, since there is no thromboplastin in the PTT, PTT is a sensitive test. It gets affected by n number of parameters. That's why a lab which is doing PTT perfectly can be rest assured that everything remains accurate enough. Okay, that's how PTT is sensitive. So every single factor has to be taken care of with proper precaution. So this formula already has been discussed, and you have to adjust the volumes of the citrate and do the repeat collection. So the repeat collection was done, and the corrected PT was 34 seconds. It was actually normal. Okay. One more case, 18-year-old male, present with acute abdominal pain with fever. Patient is a case of acute appendicitis, planned for surgery, no past or family history of any bleeding. Right? CBC is almost normal, PT is normal, PTT is 43, slightly prolonged as compared to the control or reference range. PTT is prolonged. So what to do? Next. What is desirable if there is any prolonged value? Mixing studies. So the mixing studies are done. PTT is 40 seconds. Neither corrected. So do you want to suspect inhibitors? There is no complete correction. Lupus? Yes. Lupus anticoagulant. So the lab does the DRVVT. And the ratio comes 1.28. It is weak positive. So the lab does this test on their own and conveys this result to the surgeon, asking him to repeat after 3 months. He starts shouting back. Agreed, sir? He says, I want to operate the patient now, because the patient is really in pain. I'm not going to believe all this thing. I'm sending the result. I'm sending the sample to another lab. CBC is almost similar. PT-PTT are normal. He is happy because the patient is fit for surgery. But now the question comes to us, why this variability is there? How come this variability between two labs? Let us understand this. So one has to go to the APDT reagent composition. The reagent consists of phospholipids, different activators, and calcium chloride. Okay, the sources of phospholipids can be natural or synthetic. There are different activators: silica, ellagic acid, salite. Kaolin is hardly being used right now, and of course calcium chloride. So combination of different phospholipids. Now these phospholipids also are of 4 different types: phosphatidylcholine, phosphatidylethanolamine, phosphatidylenoacetal, and phosphatidylserine. Now these 4 phospholipids in different compositions and different proportions are being added by different manufacturers, and the reagents with different activators are available in the market. So there may be around 40 to 50 reagents available in the market with these different combinations from different manufacturers. This all adds to the variability in the APDT values between the labs. Now, how do you select a reagent then? Now, this is completely dependent on the indication of APDT. So, for a routine laboratory testing, which is handling the patients of factor deficiencies or treatment of the monitoring of the heparin therapy, they should actually be using a reagent which is low responsive to lupus anticoagulant, and it is and the sensitivity of the deficiency is around 35 to 40% of the factor levels. What is it? I will just show you. Now the yellow line is the control line. This is the the blue line is the factor rate %, and the red line is the APDT value. Okay, so the 32 seconds is the control line. Now since the value of the PT is 33, 35, 37, the factor levels were okay. The 47 was the factor level. The moment the factor 8 level comes to below 35%, the APDT is prolonged. That's how the sensitivity of the reagents is defined. Okay. Now this is one article which mentions the analysis of false prolongation of APDT reagent as a part of CRP interference. Now this article mentions about the 2 different reagents, one using silica as activator, the second using kaolin as activator, third one is the ellagic acid, and this is the colloidal silica. So with these 4 different activators, if you see this the silica activator, as the CRP levels increase, there is prolongation of the APDT. That means there is significant interference of CRP as far as the APDT values is concerned, only when silica is being used as the activator, not with rest of the activators. And upon adding the lysate of thrombocytes, that means the source of phospholipids, upon adding the phospholipids, the APDT values actually normalized. That means it is dependent on the amount of phospholipids and the activators which are being used. Okay, so what the lab has to decide for what purpose they are doing the APDT, and then only choose the reagent. Okay. So these are the different reagents available. So for lupus anticoagulant testing, the LS sensitive reagents can be used. For factor deficiencies or the routine labs, the low responsive reagents for routine laboratory tests can be used. Now, with this case, this is a transient lupus. Since the patient had acute appendicitis, the CRP levels were quite high. The lab A, the first lab, was using silica based reagent, and the second lab was using ellagic acid based reagent. Now, how to handle this DRVVT scenario? The lab has done the DRVVT, but is it really worth doing DRVVT? DRVVT should never be done. It should only be done with a pre-test probability of thrombosis, deep vein thrombosis. If there is no pre-test probability, PTP for thrombosis, DRVVT or lupus anticoagulant testing should never be done. The lab did the mistake that they did not evaluate this and did the DRUT, which actually doesn't help in any ways. So proper choice of reagent is must. So there are 3 cases again, 8-year-old male, 49-year-old female, and 68-year-old male. PTT 88 second, 91 second, 52 seconds. Any information? Nobody will be able to interpret these values. First and foremost, history. The first patient has got joint bleed. Second patient is a case of DVT on direct oral anticoagulant, that is the Vigatran, but stopped 5 days back, but still the EPDT is prolonged. And this patient is a case of pulmonary embolism, and he is on heparin infusion, and APDT is being done for the monitoring of heparin therapy. Now half test, half control for this baby, there is complete correction, and there is no need to do half test, half control for this prolongation, because you know the reason for prolongation of the APDT. No need to do the mixing studies. 2 more cases, 31-year-old females, no history of bleeding. During routine ANC checkup, APDT is 82 seconds. And this lady has history of recurrent miscarriages, APDT is 78 seconds. The way to go ahead? Mixing studies. Half test, half control, complete correction. Right? This patient, there is no correction. So, how will you proceed further? Which factor? Which factor? There is no history of bleeding. Still the APDT is prolonged. So you will do factor 12 assay. Because there is complete correction. That means there is factor deficiency. There is no correction, so you will do, and there is history of recurrent miscarriages. So you will do lupus anticoagulant. Right? So this is how you have to interpret the results. Now this is some different case, last case probably. 1 month male baby. Patient has got history of umbilical stump bleed on day 8, prolonged for 20 minutes, approximately 5 ml, which is a huge quantity for that baby. Stopped after application of antiseptic powder, born to first degree consanguinity, no bleeding history, no other bleeding history or family history. Okay, 1 month baby, umbilical stump bleeding. We know if there is umbilical stump bleeding, either fibrinogen deficiency or factor 13 deficiency, most common. Okay. So on day 8, PT and APDT were prolonged with complete correction. So suspected is, so if there is factor 13 deficiency, I told you factor 13 doesn't come into the picture till the formation of fibrin. That means in factor 13 deficiency, PT and PTT will be normal. In fibrinogen deficiency, there is no fibrinogen to form the fibrin. That means PT and APDT will be prolonged. Here PT-PTT is prolonged. So we are suspecting there is umbilical stump bleeding. So we are suspecting fibrinogen deficiency, right? Fibrinogen was done normal. Factor 13 screen normal. Right? So assuming that it could be vitamin K deficiency, vitamin K was administered, but no improvement. So FFP were given. Still after 4 days, values are similar. So this was done outside. So one more key fact about the rare bleeding disorders is that the clinical heterogeneity associated with their rarity is significant barrier for the knowledge, because you cannot easily suspect these cases. because those are rare itself, and there is lot of variability in the clinical presentation. The second most important, variable clinical presentation and difficulty in recognizing the affected patients actually hampers its diagnosis, right? Now like this case. So most of the abnormal bleeding episodes are from mucous membranes for most of the rare bleeding disorders. But the most important is umbilical stump bleeding. Apart from afibrinogenemia and factor 30, it is relatively frequent in 2,5,10 deficiency also. This is never taught to us, but it is published in the articles. So this patient came to us with almost similar results. Fibrinogen normal, 13 screen normal. So we did the assays. Factor 10 less than 1%, factor 5 normal, and factor 2 normal. So this was a case of factor 10 deficiency with umbilical stump bleeding, and is definitely mentioned in the literature. So we could diagnose this as factor 10 deficiency. The baby is quite doing well. This was a case almost 2 years back which we evaluated. So to commence, there is lot of complexity in this because non-medical people are handling these medical tests. They don't know anything about the medical background, but they are doing the test, and there is a need that we need to monitor them, right? Coagulation tests are simple to perform, like how we do manually. Add 2 reagents, see the clot, and everything is done. But the results are multifactorial, interpretation is complex, and there is need of absolute accuracy. Without that, you cannot survive. So there are almost 550 medical. This is an old data. The numbers may be high now. Hardly 10% perform the factor assays. Now this is a welcome move that you are entering into these 10% of the medical colleges doing the factor assays. So congratulations for that, since you are entering into that. And there are more than 2,000, now almost 2,500, and hardly 5% of those are putting their factor 8 and 9 into the scope of accreditation. So this is the data, which is not an encouraging data. So the need is to have an adequate helpline for developing the infrastructure, selection of the equipment, availability of the reagents, the quality assurance, training of the personnel, and of course the awareness of the person who is doing the interpretation of the test. But it is nothing but like standing below this hanging piano, wherein the strings of this piano are being these helplines. If those strings are strong enough, then you are safe. Otherwise, nobody knows. So my acknowledgements to the clinical hematology team with eminent hematologists, the DNB residents, of course the Sahyadri lab consultants are always there, and we are fortunate to have the laboratory technologies team. For these 3 people are working with us for almost last 15 odd years, and special thanks to patients and relatives. Thank you, Merit. And any questions?
Congratulations for your presentations.
Thank you, sir.
Who told you you are not a good academician? I mean, I'm sure you are a wonderful clinician and you are a wonderful academician as well. The way you presented everything was nothing less than that.
Thank you.
So henceforth, I don't think you should say you are you are not an academician. Only one thing I just wanted or was wondering when looking at those results and everything. So as a clinician, as a surgeon, should I see from which lab the result is coming?
No, it's not like that, sir.
Because how would I know whatever things are going on? What reagent this lab is using and what reagent the other lab is using?
Majority of the content was intended towards the lab. So when the lab is establishing a coagulation setup, the lab has to take care of all those things. We cannot project these things in front of a clinician. like I said, the surgeon will definitely get angry. I don't want all those things.
That
I
was
want the
another.
result. I
That was
want
another
accurate
question to
result.
you.
Yeah, yeah.
What
definitely.
should I do? Whether should I operate that patient or I should not?
Yeah. So in case of such results, definitely interaction. So these discussions should be initiated by the lab. So maybe you will get lot of calls from the lab. So you have to answer those, because many times what happens, the clinician says that we are busy right now, we are in ICU, so we won't be able to attend your calls. But that's not the scenario. Lab will never call you unless and until they are into some trouble. So if such results are there with you, it is your duty to initiate a call or discussion with the clinician, see what his interpretation is, see whether the results are acceptable to him, and if there is discrepancy, then definitely we have to look into our own system. And yes, the reagent related issues, it has to be taken into consideration at the time of setting up of the lab. The pros and cons of all those things.
Okay. Thank you.
One comment, you should see from where the report is coming, in the sense that whether they are adhering to all the norms which Dr. Rajesh mentioned, that what PT should give you, what APTT should give you. In that sense, it's very important.
And in hemostasis, one more point, there is nothing like laboratory hemostasis versus a clinical hematologist. Both should be working for each other. A laboratory person should know each and every detail of the clinical background for the results. At the same time, the clinical person should know what are the pitfalls, what are the requirements from the lab angle also. So if the lab is actually in need of some clinical details, in this, the dialogue has to be there.
So thank you, sir. We from clinicians also, you have stimulated our brains to look in that way. We usually deal with PT-INR for liver disease patients and all those who are on oral anticoagulants, and rarely in the malignancy and the coagulation disorders. So thank you for enlightening everybody, and we look forward to our center with new knowledge base. Thank you, sir.
Thank you very much.
Thank you so much, sir, for insightful and engaging case-based discussion on coagulopathy. I request our chairpersons to felicitate the speaker. Thank you, sir. Thank you, ma'am. I request Smita, ma'am, to felicitate the chairpersons. Thank you, sir. Thank you, ma'am. Now, to formally conclude the today's Enriching CME program, I now call upon Dr. Mangala Nagre, Associate Professor Pathology, to kindly deliver vote of thanks.
Requesting everyone, QR code already display on the screen. Kindly scan the QR code for feedback form. Good afternoon, everyone. It's my privilege to propose a vote of thanks on this special occasion. On behalf of Department of Pathology, I extend our heartfelt gratitude to all who made this event a success. First and foremost, I would like to thank today's speaker, Dr. Anjali Kelkar ma'am, Dr. Rajesh Patale sir, and Dr. Gauri Metkar ma'am for taking the time to enlighten us with their knowledge and experience and making this difficult topic of coagulation so easy to understand. My deep appreciation goes to our Executive Director, Madam Dr. Suchitra Nagre Ma'am, our Principal Ma'am, Dr. Deepa Nair Madam, and our Medical Superintendent, Dr. Darpan Maheshwari Sir, for their constant support and encouragement in making this event possible. A big thank you to MMC Observer, Dr. Gopal Ghare Sir, for their sparing time from his busy schedule. I extend my thanks to all the faculty member, organizing team of CME for their guidance and coordination throughout the event. I also extend my thanks to Operon Biotechs and healthcare teams for their supports. My heartfelt thanks to all the supporting department, IT, electricity, maintenance and photograph department for their arrangement. Last but not least, I would like to thank all the delegates, your active involvement and attention who made truly these events a meaningful. Once again, thank you all for being here and contributing this success for today's program. Now there's important announcement for QR code displays over here. Feedback form. You kindly fill this feedback form. I request everyone please stand for Pasayada.